Assalamu alaikum, students. I am here with one interesting and important topic of orthopedics. Before starting my topic, I just want to know why you need to see these videos. Two things. These videos are very short. It covers the important points you will be asked in your theory exam, practical exam, and in your entrance exam also as MCQs. Second thing is only one topic is covered in each videos. If somebody wants to listen to only one topic of orthopedics without wasting time, you can start one video of your choice and you can complete it within no time. And it will give you a clear and concise elaboration of the topic you want to study. So today I am here to discuss one important topic of orthopedics. And as a medical student, each of you will face this problem. What is it? Whenever you have fracture, anyone in the family, the first person to be called or taken opinion of will be the medical graduate in the family. So you need to know what are the complications after the fractures, because the relative will be asking you what are the possible complications or how will be the healing process, what are the complications you need to expect, and how much time it's going to take for the fracture to heal. And these questions and doubts will get doubled when children get fracture and their parents are the caregiver and they have more queries and they are more uh, enthusiastic to know what are the consequences of the fracture in the future. So by this explanation, hope everything you people know what's the topic for today is. It's complications of the fracture. So there should be a classification system so that you can remember the complications easily. And second thing is you can expect the particular complication at particular time during the course of fracture healing. So considering the same, we classify fractures complications into following subtopics. That is immediate complication, then early complication, then late complication, and delayed complication. This all depends on the time lag of how much time after the fracture the patient is presenting with the complication. What is immediate complication? Immediate complication, the patient is having this complication within minutes to hours of the fracture. That is within no time they are if they have complication, they are going to have it. The immediate complications are bleeding resulting in shock or vascular injury. Like patient has fracture around the elbow, around the knee joint, and it caused direct damage to the popliteal artery or the brachial artery. Same way, direct injury to the nerve at the time of the fracture. These all are immediate complications. Then if patient survives the immediate stage, then there is risk of patient having early complications. Early complications happens within hours to early days after the fractures. This complication may just affect the fracture site or this may affect whole body of the patient. So if they are affecting only the local at the fracture site, those are infection, soft tissue damage, or compartment syndrome. You just need to remember the names now. Later on in coming classes, I'll be explaining much more about each complication, each important complication. Among the early systemic complication, you have deep vein thrombosis resulting in pulmonary embolism, disseminated intravascular coagulation, fat embolism, crush syndrome, myositis ossificans, bed sores, gas gangrene, and tetanus. Then if patient survives early complication, he enters into the phase where he is at risk of developing late complications. What are the late complications? It happens in days to months after the fracture. So these are delayed union, non-union, malunion, cross-union, Sudex dystrophy, late nerve or tendon injury, Walkman ischemic contracture, joint stiffness. And later on, maybe after years, patient might have forgotten the fracture. He may have these complications. These are non-union, avascular necrosis, arthritis, joint instability, growth disturbance and limb disturbance. These are very important topics because very important complications because this happens in growing skeleton, that is pediatric population. When patient has fracture in the pediatric, the children, they have fracture, they are having the risk of this complication. This is due to possible epiphyseal injury. So you need to remember all this complication. If you classify it properly as immediate, early, late, and delayed, it will be very easy to remember and very easy to recall during the examination. So we'll start with the first complication, which is one of the common presentation after the fracture. So let's start with a case. It's a 30-year-old male patient. He had road traffic accident and closed fracture of tibia. Then patient was having pain, but the pain is very intense after 3 hours of the fracture. And whenever the patient is moving the toes or whenever the caregiver is moving the toes, he is having intensive pain. Then on examination, leg is appearing pale and fully palpable distal pulses. So this scenario should direct you towards the possible diagnosis of compartment syndrome. Compartment syndrome. So if you see the picture here, this is a normal leg. This is the fracture leg. If you see there is swelling, very tense, shiny skin. This is the clinical picture of compartment syndrome. If patient has compartment syndrome, he present to you with this thing. So how will you define compartment syndrome? Compartment syndrome is osseofacial compartment pressure. It rises to the level that decreases the perfusion of the leg. So it compresses the vascularity and decreases the perfusion, which latter results in irreversible muscle damage or neurological damage. So it may damage muscles, nerve, vessels, this pressure. So if you see here, this is tight osseofacial compartment. So fascia lining here, then you have bone here with the interosseous membrane bone. So here you have nerve, muscle, and vascularity. So whenever there is a fracture, there is fluid accumulating here in the form of hematoma and excavation of the interstitial fluid. So this causes compression, increases the pressure inside the compartment. So once there is an increase in the compartment pressure, the vessels which are open, they get compressed. So this decreases the blood flow. So what are the causes of compartment syndrome? Causes are trauma. Trauma is common cause. Among the trauma, it may be a fracture. Sometimes it happens without fracture in the crush injuries, contusions, and gunshot wounds. And after the fracture or after something surgeries, if someone applied the tight cast or tight dressings or tight external wrappings also, this may hamper the blood flow and the patient may land up in compartment syndrome. Then extravasation of IV fluid. This is common finding in ICUs. So patient is comatose or patient will be on ventilator, nurse keep on putting the IV fluid. Sometimes the fluid or IV line missed the proper vein and the fluid will enter into the interosseous interstitial structures and in the compartment and causing increase in the compartment pressure. So you need to be very careful about this one when you are dealing with the ICU patients who are unconscious and on ventilators. Then after the burns, there will be interstitial edema after the burns. Then post-ischemic swelling. This happens after the surgery. Sometimes some surgeon forgot to remove the tourniquet. There will be increased pressure inside and patient may have presentation of compartment syndrome. Bleeding disorders like hemophilias. This patient have spontaneous bleeding inside the compartment, which increases the compartment pressure and compress over the vascular flow. Then direct arterial injury. So these are the few causes where the patient can have compartment syndrome. So what is the consequence? What happens in compartment syndrome? So whenever there is local trauma, what is happening after the trauma? There will be soft tissue destruction. When soft tissue destruction, there is bleeding and edema inside the compartment. So the content of compartment increases and this increases interstitial pressure of the compartment. Increase in the interstitial pressure further cause vascular occlusion because this interstitial collection will press the vascularity and it decreases the arterial flow. and this arterial flow is persists for longer time, it may called ischemia of the muscles, ischemia of the nerve, myoneural ischemia. This is how you can see here. This is the bone, this is the bone, and this is interosseous membrane and the tight facial membrane. So this is osseofacial compartment. We have vessel here, artery here, nerve here, and the muscles here. When there is increase in the pressure, it will affect the nerves, it will affect the muscles. So there may be, if it there for the longer time, it may damage the nerve and the muscle completely. So how, when to suspect and how the compartment syndrome patient presents. So you need to remember 5 P's. What are 5 P's? One is pain. So patient will have intense pain. As I described in the beginning, in the classical case scenario, patient was having pain, but the pain increased after 3 hours of injury. So sudden increase in the pain or pain out of proportion. Pain out of proportion. And in the case scenario, I have told you that patient is having pain in the pain after the movement of the toes. It is pain on passive movement. So these are the two things you need to see in the patient who is having fracture. If this is coming positive, then you need to suspect patient may have compartment syndrome. Second is pallor. This pallor is due to obstruction of the blood flow. The patient develop pallor in the distal part of the lip. Then pulselessness. Pulse will be missing. So there will be pulselessness. Then there will be paresthesia. This is due to crying of the nerve for the blood supply. Then if it stays for the longer time, patient may have the permanent damage to the muscle and the nerve tissue. That is myoneural damage resulting in paralysis. So this is what it happens. So there will be compression by the blood vessels to the nerves, and patient may have muscles damage and the nerve damage and present with compartment syndrome. So what is the presentation? As I told before, pain out of proportion or pain on passive stretch. These are very sensitive. If you find this thing, then you need to think of ischemia of the limb, that is compartment syndrome, and you need to intervene. Then pallor, pulselessness, paresthesia, then paralysis. These are the clinical findings you will see in the patient who tends to have compartment syndrome. How will you diagnose? Compartment syndrome is always a clinical diagnosis. If you suspect compartment syndrome, then start treating it. Don't wait for any diagnostic parameter for diagnosing the compartment syndrome. If you feel that patient is having compartment syndrome, you need to make your mind that patient is having compartment syndrome and you need to intervene it. The other way of diagnosing compartment syndrome is measuring the compartment pressure. So normal compartment pressure is 10 millimeters of mercury. If the pressure is increasing more than 30 millimeters of mercury, then it's for sure compartment syndrome. But mind you, again, it's a clinical diagnosis. If you think that patient is having compartment syndrome, he is having compartment syndrome. Don't wait for any investigation. So this is how you measure the compartment syndrome pressure. Pressure in the compartment, any compartment. So you put some needle, then you have a barometer here. Over that, you will get the reading. So this is how. So if patient is having more than 30 millimeters of mercury, then patient is surely having compartment syndrome. Then once you have diagnosed, you need to treat it. Why you need to treat it? You need to prevent the patient developing permanent neuromuscular damage. So you need to treat it as emergency as early as possible. So before you take the patient to operation theater, you need to try your conservative method to decrease the compartment pressure. How will you do it? You can give mannitol, forced diuresis. So what is the advantage of mannitol? Mannitol will take away extracellular fluid. So this to some extent decreases a compartment syndrome, but it is not the treatment. It is just supportive treatment till your operation theater is ready. You give high pressure oxygen, because whatever limited blood is going to the compartment or muscles, it should have maximum oxygen in it. So high pressure oxygen, and remove all the external compression like POP cast, dressing, cast, everything, leave everything open. So that external components which is pressing the compartment should be decreased. Then surgery. Surgery is emergency. We need to release the compartment pressure by doing fasciotomy. And remind you, after doing fasciotomy and opening the fascia, don't close the wound. Leave the wound open for either secondary healing, or later on you can go for skin grafting in the elective process. Because if you close the wound, again, it become a tight compartment and chances of further having a compartment syndrome or incomplete treatment is high. So what are the complications of compartment syndrome? If there is decreased vascularity for longer time to the muscle, they have lysis of the muscles. So patient will have rhabdomyolysis, resulting in myoglobinuria. So this may result in acute renal failure. It may result in acute renal failure. Acute renal failure. This is you need to ARF, sorry, there is some problem in my pad. ARF. Then if it is there, then there's ischemia, there will be infection, renal failure. And if you leave it for longer time, there may be a permanent damage, and final treatment for this one is patient may lose the limb by, you need to do salvage amputation. I think you remember one incident recently, there is in Haryana. What happens is there was one, I think female football player. She had ACL injury. After ACL injury, they have operated in some hospital. They forgot to remove the tourniquet. It was, I mean, it was in discussion for longer time. So what happens is the tourniquet they forgot to remove. So due to this, there was damage and myonecrosis. When they remove it, patient had compartment syndrome, so they did amputation. But it was very late by the time they did amputation. So patient landed with multi-organ renal, multi-organ systemic failure, dysfunction, and finally she expired. So this is the importance of early. This tells you that how important the treatment, early diagnosis and treatment. Treatment, not only treatment, but early diagnosis. Early diagnosis is important. Early diagnosis is important for the prevention of complication of compartment syndrome. So otherwise you may lose the patient. And if you treat little late, there may be permanent damage to the nerve. So there will be numbness forever and weakness forever. Then they will be due to that, they will have constant nerve pain. Then if muscle is damaged, it will replace by the fibrous tissue and patient will have contractures. So this is all about acute compartment syndrome you get after the trauma. What I told is acute compartment syndrome after the trauma. Syndrome after trauma. So there is one more entity. It's not very common, but it may sometimes be asked in the question, and you need to just know a few things about it. It is external compartment, exertional compartment syndrome. What is exertional compartment syndrome? In athletics or new athletics, we get this in new athletics. So the new athletics, what happens is they run for the longer period of time. So there will be increase in the blood flow. So it is of two types, chronic and acute. What is happening is chronic is it is happening every time they are running. It is called as recurrent reversible ischemic episode, which causes pain and make the patient to take the rest. When patient takes the rest, everything settles down and pain will improve. So cessation of activity, this causes decrease in the facial compartment pressure and reduces the pain. What is acute exertional compartment syndrome? The same thing, it is happening as an acute presentation without reversing after the rest. It is called as irreversible or acute exertional compartment syndrome. And it may land up in acute compartment syndrome, how we find it? Post-traumatic with the same consequences. So what is pathology here? What is happening is when you do the exercise, the muscle compartment swells up to 20% of their primary side. It is secondary either due to the increase in the blood flow or the fluid volume in the muscle. So the compartment which has to encase 100%, now it is encasing 120% of the tissues. So that increases the intra-compartment content. So in few patients, the fascia is very rigid. It may be due to scarring after the injury, some other injuries, or it may be hereditary. So it is less stretchable. So to accommodate 100%, it need to be normal. to accommodate 120%, the fascia need to get stretched out. So this stretching is not happening because of either scarring or rigidity of the fascia. So Zahida, there is increase in the pressure inside. So this inhibit the further expansion of the muscle, eventually compromising or compressing the blood flow. Then finally, patient will have decrease in the capillary perfusion pressure and patient will end up in symptoms of compartment syndrome. So how will you diagnose? This is by clinical evaluation or by measuring the compartment pressure after exertion. The treatment for both is fasciotomy. For the chronic compartment syndrome, chronic exertional compartment syndrome, you can do it electively. You can select the patient, take proper time and do the surgery. Whereas in acute exertional compartment syndrome, you need to do immediate surgery. Immediate surgery. One thing I forgotten here to explain. If you see here, this is the leg. So this is your fibula. This is tibia. Tibia, fibula. Then this is your lateral compartment. This is your anterior compartment. These are the posterior compartment, posterior superficial P1, P2. So if patient is having compartment syndrome and you are suspecting increased compartment in the lateral, posterior and anterior. So what will be the treatment? You can't go on doing fasciotomy of each compartment. So this is one of the common questions you will be asked in practical examination. So what you will do if patient is having compartment syndrome in all the three facial compartment? So the answer is you need to remove the fibula. So you need to do partial fibulectomy. What is the advantage of fibulectomy? If you see here, the fibula is having attachment to the anterior facial compartment, lateral facial compartment, and the posterior facial compartment. If you remove the fibula, all the compartments are getting decompressed. So fibulectomy is the treatment for fibulectomy, for treatment for leg, all the three leg compartments. Three leg compartments, fibulectomy. Fibulectomy is the treatment for three. This is the incision we give for the hand, impounded compartment, and we leave it open so that there is we won't close it, and over the period of time when the compartment settles, we can put a skin graft. So thank you for listening to the video. Please share and subscribe and share with your friends so that everyone gets benefited. If you need any changes in the next class, please message me in inbox. Thank you for listening.